My name is Rachel Wald. I'm the Vice Chair of the Scientific Statement. I'm a pediatric and adult congenital cardiologist in Toronto. I'm a professor at the University of Toronto, and I'm also the Research Director of the Toronto ACHG program.
In addition to Rachel, we have Dr. Carlos Mery from the Department of Cardiac Surgery at Vanderbilt University in Nashville, Tennessee.
Dr. Mery, can you please describe the state-of-the-art indications for and results of surgical PVR? And what is your perspective on the choice between surgical and transcatheter PVR currently and in the foreseeable future?
In terms of surgical valve replacements, there are multiple different types of surgical valve replacements that we use. But in general, I think they can be categorized into stented bioprostheses, either bovine pericardial prostheses or mounted porcine valves. And these are the most common valves that are used because of their durability, availability, no need for anticoagulation, and just the ability to provide a landing zone for transcatheter valves. The other big category is going to be your biological conduits, and that includes homographs, both aortic and pulmonary, bovine jugular veins conduits, and bioprosthetic conduits that include either a bovine pericardial valve or a porcine valve. The results of these different types of surgical valve replacements are good overall. Most studies report a perioperative mortality of between 1% and 2%. And there's some degree of pulmonary valve deterioration with time that tends to occur about 10 to 15 years. In terms for indications for pulmonary valve replacement, I think those have evolved. Before, we used to have very simple guidelines based on right ventricular diastolic volumes. But I think we now have recognized that there are many factors that should play into when is a good time to replace a pulmonary valve, either surgically or transcatheter. And that includes different factors like age, obesity, the type of anatomy, right ventricular function, left ventricular function, and yes, some of the systolic and diastolic volumes. In terms of how to choose between a surgical and a transcatheter valve, I don't think that comparing them both is necessarily the best way to go about this. I think they're both complementary to each other. So it's almost like a chessboard, and we want to get to a particular point. So what is the strategy for this particular patient that's going to make sense? And that will include a combination of surgical and transcatheter valves throughout the entire approach. So just a coordinated approach between surgeons, interventionalists, and cardiologists is the way to go. Now, in terms of a particular aspect, there's going to be considerations in terms of patient, provider, technology, anatomy of the right ventricular outflow tract, whether the patient needs other interventions that need to be done surgically or not. What are the number of sternotomies? What is the risk for that particular patient in terms of surgical risk, whether it's endocarditis or not, whether the valve needs to come out. And I think all of these factors in a multidisciplinary fashion are what should allow us to decide whether for that particular instance, the patient should have a surgical or a transcatheter valve.